Thank you, first of all, to Clinician for having me out. I grew up the road in Jackson, Mississippi, and I used to spend just about every weekend down in New Orleans all through high school and college, so it's nice to be back for the first time in quite a while. So they did these slides. Every time I look at that, I feel like that's a pregnant woman holding her belly when I just glance at it quickly. It throws me off every time. That's neither here nor there. Okay, so Prox Physical Therapy. We have 15 clinics in New England, mostly in eastern Massachusetts and the greater Boston area. And the reason I throw this up there is that this is our mission statement that we live and breathe every single day. Having an impact upon the profession is the most important thing that we're trying to do. We're trying to change the way physical therapy care is delivered, we're trying to change the way that it's perceived in the marketplace, and we feel that the way we're going to be able to continue to do that is through growth. So we have to have a certain amount of critical mass in order to have an impact upon things. But we also feel that we have to do it through engagements like this, where we can come and hopefully I can share with you guys some of our successes and our failures so that you can hopefully profit from them as well. The other thing that's great about our organization is it all starts with patient care. So everything we do as an organization starts with that interaction between patient and therapist. And all of the business systems that we've built, all of our metrics, all of our financials, everything related to the organization rolls from that interaction. And if that interaction is not improved based upon whatever we're looking to implement in the business, then we're not going to do it. And that's a fun place to be, right? It's a fun place to be that we can make business decisions starting from the therapist-patient interaction and do it from a place where we're coming from the right place, so that, right? We're coming from a place where the patient is truly at the center of everything. So this isn't going to surprise any of you guys that the physical therapy industry is in flux, right? We're probably moving. Well, we are moving, but at different rates, right? In New England, we tend to be the last to adopt anybody for anything. So some of you might already be faced with a fee-for-value system, bundled payments, CCJR, all that sort of stuff that's going on. But what we think that we can say with pretty good certainty is that as we move from a fee-for-service model to a fee-for-value model, that the three most important things for us as physical therapists, PT clinic owners, all those things are the outcomes that we're providing our patients. Are they getting better or are they not? How satisfied or what's the perception of this customer service experience? So people, not only are they getting better, but do they want to or enjoy coming to see us? And finally, what does it cost? What does it cost for us to deliver the care? What does it cost for the insurance companies or the third party or whomever to pay us? And so those are kind of the three tenets that we're constantly looking at, right? Those are our buckets that we have to continue to drive, those outcomes, the satisfaction, and the cost that we do it at. So historically, as an industry, these are all the things that we've done, right? So this used to be perceived as a good thing. Variability in care. If I had two different therapists at my clinic, one doing one thing and one doing another, that's good, right? I can have, if Mrs. Jones doesn't like the approach of Bob, then she can go over and see Sally, and that's a good thing because she's going to get different care. We can appeal to more marketplaces. We can say yes when someone asks us, do we do fill in the blank? But I just want to talk about this today and hopefully challenge a few of the perceptions around variability being a good thing versus a bad thing. Because frankly, as we move forward to a value-based payment model, you're going to be asked a lot of questions from people, primarily payers, about the outcomes that you're producing, the widget that we produce, the patient satisfaction, the service experience, the clinical outcomes, the costs, all those things. That can you as a business owner say to someone when they ask you if you have turnover in your staff, if you add another clinic, if you lose a provider, can you deliver the same care or is it going to change? That why is the care from two different people different? And are you looking at that outcomes data that you just talked about with photo? Are we looking at it on a therapist level? If we're seeing variability from therapist to therapist to therapist, is that something that we have a system in place to address to try to figure out who's doing it best and how? And obviously, how does it all relate to cost? What's interesting about all this, though, is Some of our responses have been through networks. I don't know if any of you guys are involved in professional networks, that sort of stuff. There's one in New England that they actually have put together an IPA around, and they think that they're going to be able to go to a payer and say, hey, we have this coverage, we have, I don't know, 50, 75 clinics, and we're coming to you and we want to negotiate a better rate. If I'm a payer, what I would ask is exactly these questions plus others. Why on earth am I going to give you more money when what all 50 of your members are doing is completely different? You're not a monolithic block that can somehow come to us and demand more, because frankly, I don't know who's better. I know you're all doing something different. How can you possibly pool your data? How can you come together and give me data that says that you're better than everybody else? But why? You don't even know why. So that's where the problem comes in the variability of care. We're getting all this great data out of our EMRs on satisfaction, on outcomes, on things, demographics, anything, and we can slice it and dice it however we want to. But at the end of the day, can you truly pool the data from your various therapists in your system in order to actually make some conclusions? So healthcare in general, I'll go back to the example of ACLs. This is a perfect example. If you tear your ACL, you can have surgery or you cannot have surgery, right? They're kind of two treatments. There's a conservative approach. There are various surgical approaches, but those are essentially your buckets. Think about how many treatment possibilities there are for low back pain. It's an easy one, right? I can go to PT, I can go to chiropractic, I can go to massage, I can get acupuncture, I can go get on medication that Sturdy is going to talk about later. I can, what are the other ones I'm missing? Injections, surgeries, all these sorts of things, right? And the reason why, because we're not very good at treating it. If we were good at it and we all had some unanimity around what it takes to get that patient better, then we would all just do that, right? So what we need to be able to do is to have a philosophy in our own organization that says, even though we might not have today the proof that everything that we do leads to this outcome, that this is how we go about it. That we have a belief system around how frequently should we see our patients, how long should we see our patients for. We talk about the same church and the same pew. So if you guys in your organization have two different therapists, how confident are you that those two therapists are going to see the same patient and come up with the same diagnosis? Because that's problematic if they don't, right? If we don't have the same system for diagnosing people and trying to figure out is it a hamstring strain versus a lumbar radiculopathy, that we're going to be doing two different things for that patient. That's going to create more variability. It's going to inherently lead to more cost, right? Because if we're treating two different things, hypothetically one person's right and one person's wrong, and the person that's wrong, eventually that person's going to need more care and it's going to become more costly. So we talk about a clinical philosophy in our organization a great deal. What are the parameters around which you operate? What do you think is important for patients? What do you think that it takes to get patients better? And then how can you train that into your employees? How can you make that part of the fabric of your organization? And so we talk about R&D expenses. The guys at Clinician right there, you spend a great deal of money in research and development, as any software company does. In PT, if you look at the P&Ls of most of our businesses, you don't have a really big line item to R&D expenses typically in our industry. But what if we were to start taking a look at continuing education dollars as an investment in research and development as opposed to an employee benefit, which is where most of us, here's your $500,000 a year, whatever it is. But instead of people just going and picking all those things I put up on the slides around, I'm going to go do this yoga stuff or Pilates stuff or dry needling or manipulation or whatever it is, what if those dollars were actually spent creating less variability in your clinic, creating a system by which we evaluate and treat our patients, and trying to train that back into the system so that we're all in the same place and doing the same things. And then is where we get to the crux of this. How do we then monitor, give feedback, give coaching through the data that we're able to pull out of an EMR so that it's concrete, actionable change that we can affect in our organization to support a treatment philosophy? So this is us. This is how we treat patients, and The reason I want to go through this is just so you see that this is how we operate every single day. We are all trained as manual therapists. I'll get to that in a second. So advanced manual therapy skills are very important to us. The expert exercise prescription, we believe in dosage of exercise in the same way that you dose any sort of medication, and different doses are going to lead to different things. We also have a tremendous focus on the biopsychosocial approach, and meaning every person is going to be different and require different things, and we have to be skilled at the psychosocial aspect of rehab, not just the biomedical, right? We all went to school and we got a really great biomedical education. Those of us that went to BU might have been better than others. What about the psychosocial components? What about that therapist's interaction with the patient, how that can either help facilitate recovery or not, based upon their interaction with the patient? Our belief is that PTs are the single most cost-effective healthcare providers for all musculoskeletal disease, and that we can become that primary care provider in the world of musculoskeletal care and orthopedics in order to help the system as a whole consume less care, get to the right outcome quicker and cheaper. But we also don't think every therapist is prepared and ready to do that the day they roll out of PT school or the day they get hired by us. And so we need to find a way to provide that additional level of training and expertise so that we can get to that place. And finally, the variability of care leading to greater cost. So we have this clinical philosophy, right? And then we needed to come up with some sort of system to train our people. So we are, in partnership with Boston University, actually founded an accredited fellowship program with the APTA in orthopedic manual physical therapy. It's great. We're producing tremendous fellows that are coming out. We're going to have 75% of our employees, of our therapists, so that's 35 therapists, are going to be full fellows in the American Academy by the end of next year. And our goal is to continue to have that rate going forward, that you're either a full fellow or you're in process of training to become a full fellow. But we also knew that we had to get people from just beginning to be educated, or just beginning to work, and into the fellowship program. There was still a gap there, right? So we actually recently started a partnership with the Institute of Orthopedic Manual Therapy in Woburn. It's Martin Langus's program. I don't know if any of you are familiar. So Martin was actually trained by Olaf Evgenth himself, who then trained Martin and now is training all of our people. And the reason we're doing all this is not just because we wanted to work with our alma mater or because we really like education or things like that. This is what's driving our business. We have to educate our therapists on a systematic way to evaluate and treat patients so that as we grow, we can continue to develop, so that we can continue to get the same outcomes from our patients. They can do it in an environment that is scalable, and we can move forward. So that's the systematic training piece. That leads to less variability. If our therapists are all trained similarly, if they have similar beliefs about how to go about their job, then there's going to be less variability. That then creates a very repeatable and measurable outcome that we can provide coaching for our therapists on how to get better and when to get better. And it's a really cool thing when you have this system, because that is what allows us to just continue to grow without having to worry about, are we growing too fast? Are we still delivering the same outcome we did when we just had one location? Because we have the data to back it up, and we have the system in place to give us the feedback when things aren't right, but also the system in place to continue to fuel that growth with really well-trained therapists. So there are two kinds of data that we're really looking at in our organization to help reinforce that clinical philosophy. And we're essentially looking at behaviors of clinicians, so how are they operating day to day, and then the outcomes that they're producing. So we're going to talk a little bit about those, but these are obviously the sources that you can get it. The beauty of the day and age that we're operating now is that there's more data available to all of us than ever before. And the problem is, you can quickly become overwhelmed with it, right? There's so much out there that how do I slice it and dice it in order to make sure that it's actually helpful and I'm not just, getting kind of a popsicle headache from looking at it all. So let's just do a little quick case study here. I created clinician physical therapy just to prove a point. So this is an outpatient practice with 3 clinicians. They do orthopedic, sports medicine. Let's assume for this case, normal distribution of payers, demographics, all that sort of stuff. So the first thing I would want to know about clinician physical therapy is what's important to them. How are we going to go about doing our day-to-day work? What is it that separates clinician physical therapy from everything else? What is it that gives them a market advantage, but also maybe an identity, a soul, a culture? And then what we have to figure out is, once I identify those things, what kind of training and support do my staff need in order to buy in on the first part to the clinical philosophy, as well as stay there and make sure that I'm staying on board and on topic, if you will. So this is actual real data that I've pulled from a client of ours. It's another private practice that we work with. I've de-identified everything, obviously. But these are the things that we start to look at. These are the basic metrics that we all have very quick and easy access to. How many visits did you do this week? How many new patients? How many did you discharge? Patient frequency of care is a big one that we're going to come back to. We measure for our therapists, how frequently do your people come? If you guys were to leave this room today and go talk to every one of your therapists that you work with, I guarantee they all say, well, at least 2 times a week, right? Guarantee they say it. If you measure this, there's no chance they're at 1.6, 0. So, right, so you have an evaluation that just started at the end of the week, so they only got in 1 time. I got somebody else who's discharged early in the week, so they only came once. I have 10% of my people or maybe are canceling or no-showing. I have other people that just fall off the radar, that are traveling, that are doing this and that. So our motto is, if you're not coming to physical therapy is not getting you better. I'm positive of that. So there might be a placebo effect, but it's not that quite strong. So frequency is something that we're monitoring because we have a belief system on what it takes to get people better in terms of the frequency of their care. Productivity, obviously, is something we're all looking at from a business standpoint, but this is a number that we're looking at from both sides of things. I feel like I'm going to fall off here. Take a step away. We all need to be productive. We all need to create enough revenue in our business to keep the doors open. You know, one of our sayings is, there is no mission without a margin. If we can't pay to keep the lights on, it doesn't matter how lofty our goals are. But we also need to make sure that number doesn't go too high, right? So for us, we know where our sweet spot is in terms of productivity. It tends to be in that kind of 58 to 62 range. And if things get higher than that, we're concerned about the service experience suffering. We're concerned that it's going to suffer either because there aren't enough kind of seats on the airplane for people to get in and get the care that they need, or we're concerned about when they're in, they're not going to feel as good about their care as they did if they were getting fewer visits. So we have to have systems in place to monitor that customer service experience, which we'll talk about here in a little bit. So this is kind of aggregate data of all my clinicians at the same time, right? But then I want to split it up, and I just want to look at the at the clinician level to see how are these 3 therapists whose data I'm all pulling together, how are they actually performing versus one another or versus the standard, the budget. So when I'm looking at the same exact thing, frequency of care, productivity, cancel no-show rates, all the usual stuff, right, that was just on the previous slide. But what's interesting here, if you look at these numbers, they're all over the place, right? So I have one therapist who's doing 1.67 visits per active patient or patient frequency. So that person, on average, their patients are coming 1.67 times per week. And I got somebody else who's doing 1.29. That's grossly different, right? Something there is not the same. Same thing on the cancellation side of things, right? All over the map. The productivity side as well. So what I see here, is 3 different people doing 3 different things. That's just from data. I don't know why. I don't know who's right. I don't know who's better or worse. This is just data. But I can see from looking at this that PT1, PT2, and PT3 are not the same. And nothing here suggests to me that there's a systematic way of going about things. But then I want to take an even deeper dive into the data and actually find out not just what is this person doing during the course of their week, but how are they treating their patients? How long do their patients come for? And during that time that they're there, what the heck are their patients doing? So this is all data. Like I said, we are clinician users. We pull all of this data from clinician, and we slice it and dice it our own way, and we start taking a look at what are people's collections per visit. And these numbers are totally random. I realize some of you in here would give your right arm in order to get $112 a visit, and I realize others of you would have to, liquidate assets if you're only getting $112 a visit. So ignore that for the moment. What we're looking at here is how many units are you billing per visit, right? And I know Nancy's still here in the back, so I'll make a caveat. Hi, Nancy. That I am not a compliance expert. Nancy is. That's why we actually use her services as a customer. And we're going to assume for this case, I actually have taken all Medicare data out, right? So we have two different expectations of how we treat and schedule patients for a variety of reasons. So none of us look good. Despite my tie, none of us look good in orange. We don't want orange jumpsuits. So Medicare is a whole different beast that we're very careful about. But in this case, if people are billing correctly, if they're billing what they're doing as we should be doing, what I see is PT2 sees their person for 3 units, right? So that's anywhere from 38 to 52, did I do that math right? Minutes per case. Whereas these other guys are doing closer to 4 and above. What that suggests to me is that that PT2 is not seeing his or her patients for as long a duration during each one of their treatments. The other things we can take a look at are the actual codes that we're billing, right? So in that makeup of their units per visit, what are they doing while they're there? So from our CPT codes, we're not using a whole heck of a lot of them. It's not like you're running a primary care practice where they're using hundreds of codes. We essentially are looking at those 4 kind of active codes that we really pay attention to, the 112s, 530s, and Therax stuff. So what we're looking for is the bulk of the time that our therapists are working with a patient, what's the patient doing? Are they lying on a table and getting passive treatment, which doesn't fit with our clinical philosophy, or are they active and are they moving? And so this is just another way, another piece of data that we can be analyzing to take a look and see what is happening from a data perspective. How can we take the data and recreate what's happening with our therapist and that patient-therapist interaction to make sure that we are doing what we say is important. And all of our therapists know exactly what it is that we think is important. And we've gotten buy-in from 100% of them. So if what you tell me is that you also believe that skilled prescription of exercise, that advanced manual therapy techniques, and really having a biopsychosocial approach to care is important, you can't be seeing every single one of your patients and putting heat, ice, stim, ultrasound only on them and sending them out the door. Those two things don't match. And this is a way for us to monitor that and frankly give feedback. Okay. So I talked about this at PPS this past year a little bit. This clinic, this fictitious clinician physical therapy we've just used, I actually call it, that's a barber shop more than it's a physical therapy clinic. And the reason I say that is when you pick a provider, you're picking your treatment in those 3 things. You're going to come for a different amount of time. You're going to come from a different frequency. What you do during that time is going to be different depending on who you choose. And the worst part about it is the average consumer isn't actually even making that choice. They're just calling and they're at your whim, whoever you schedule them with. And it's just a tough way for us as a profession to really try to, kind of move the ball forward and try to get to a place where we have a seat at the table when it comes to primary care, becoming primary care providers in the world of orthopedics. At the same time, though, I can't also tell you who's doing it right. I don't know if someone's coding correctly or not. I don't know if person A or person B are doing it more correctly than the other person. I have no idea. But what I do know is that looking at that, there is no evidence that there is a systematic way to treat patients in that practice with people adopting it and adhering to it. So if we were to fix this, these are the sorts of things that you all maybe can take this back to your practices and be thinking about the next time. What do we believe about frequency of care, duration of care, and what we do during those times? And I'll fully share what we believe as a company. We think that patients on average should be at our office twice a week. We also know that 10% of people are going to cancel, and there's another 10% of kind of fudge factor, if you will. Our expectation on frequency of care is that every therapist in our system sees their active caseload 1.6 times a week. So that's that. We start out at 2, we subtracted 10%, and then we subtracted another 10%, and that's where we ended up. And then the duration of visits. We tell our patients you need to be here for twice a week. You're going to be here for roughly an hour a time. Therefore, we're going to start monitoring the duration of care, and we're going to monitor it through actually taking a look at CPT code use. How many units are you billing for? To see, are you in line with what we all agreed ahead of time was important to get people better? And finally, what does the treatment look like? What is that hour, that 4 CPT code that you've chosen? What are they, and how does that tie back to what our philosophy is or isn't? Does that all kind of make sense? Okay. So I'll stop for a second. Does anybody have any questions? We're going to get to the outcome side of things and monitoring what we're producing next. But while we're here, Jerry, I knew you'd have a question. Yeah, it's an excellent question. Did everybody hear it? Jerry's asking, do we lean towards hiring new grads versus experienced therapists? It depends is the short, horrible answer. New grads are great for us because we have these fellowship programs and residency programs. We tend to be a destination for new grads that are looking to be lifelong learners, and so we have a really solid pipeline, plus we take a ton of students through the system in order to be giving back a little bit more. We are totally willing and do hire people with experience that are coming to us. They just have to be a good fit. You know, if they come from a model and working at a place where, you know, it is kind of treat them and street them, it's not gonna work out. So it's just got to be the right person, and we're very picky about who we hire because of that, and because we know frankly, this is one of the failures that we've had. You know, as we grew, we've made some bad hires, during the course of 15 years, and if we look back on when those people that we hired that didn't work out, one of the biggest reasons that we look back at and identified as a reason that we needed to fix was when we made a hire out of need. So when all of a sudden we had an open spot, we needed to plug a body in there, and we went too fast. And so for us, we just don't do it anymore. And we also are constantly recruiting for that very reason, because if we have a spot, I want to be able to pick up a phone and say, hey, I got a job for you, as opposed to, oh, now I got to advertise. Now I got to go find something. And by the time you do all that, you're 60, 90 days in. All right, so let's talk about system output, right? So when we talk about system output, this is truly what we are talking about, is that we have a patient that walks in our door, and that person experiences something with us. They're going to get care. It's going to happen in a physical environment, in a customer service environment, and that's going to lead to an outcome, right? And all of that is going to cost something. It's going to cost me something to provide it, and it's going to cost someone else something to pay me for that time. But the actual output are two different things: the clinical outcome and the patient experience. And we talk about this ad nauseum in our organization. When we get people better, we have only met their expectations. No one has ever walked into a healthcare facility expecting to get worse or not get better. Maybe it has happened, but it's probably not a good thing, right? When people come to us, they come because they think that we can help. They think that we can lessen their symptoms, help them get back to whatever they're trying to do. So we've only met their expectations when we've done that. We need to exceed their expectations through the environment in which we practice, through the customer service experience, and all those other avenues. And that's what's going to create the patient experience. We need data on clinical outcomes through photo or ROMs or web outcomes, whoever you use. And we need data on the patient experience as well. And we're going to talk about the patient experience in a second, but what I'm here to say is our patient satisfaction scores and surveys are worthless. Because I guarantee you've never met anybody who scores less than 95%. And if that's the case, we don't have any actionable data. We don't have anything that we can actually monitor to see if my productivity does skyrocket. In the example I showed you before, is the customer service experiencing suffering or not? Those are things that I need to be able to monitor, and I need a tool that's going to have enough sensitivity to be able to tell me when there actually is change. So we just talked for an hour about photo and about clinical outcomes and how to do it. It's no longer a question of if, it is a question of how. How are you going to do it, and what's going to be right for your practice versus my practice, my two different things, and that's okay. But we need to be doing something. And we need to be doing something because that's where payment is heading, for one reason. We also need to do something because it's going to allow us to monitor our own business and find out, are we truly getting people better across all of our therapists, just some of our therapists, with all diagnoses, just with some diagnoses? These are all factors that we need to be able to slice and dice the data in order to make some conclusions and have some, frankly, some actionable data that allows us to do something. If we're truly going to aggregate that data and pull it all together and make a conclusion for marketing purposes, I go out and I say, hey, we get people better than everybody else. Or if I'm doing it from a just an analysis education part as far as how is my clinic performing, we can't pull all that data and make collections without a clinical philosophy, without some sort of unanimity around how we get people better and how we go about diagnosing and treating them. So because of that, that's clinical outcomes for a second, because we already talked about that. What we really, really want to focus on is that patient experience and trying to get some sort of data from some sort of tool that gives us something that's actionable. We need to know, when are patients not happy? Why are they not happy? How does their perceived level of experience change throughout the course of care? So meaning, do they love us on initial eval, but they hate us by the end, or vice versa, or something in between? And all those are pieces of data that we can take a look at. And oh, by the way, if you have that new grad, like Jerry mentioned, that we hire, how does that new grad's patient experience, not just clinical outcomes, but how does the patient experience stack up next to the fellowship-trained therapist that I've had in my system for 5 years? Because that's going to tell me a story, right? If I'm investing, which we do, hundreds of thousands of dollars into educating our people every year, I got to have something to show for it, right? I'm not doing it just out of the kindness of my heart. Hypothetically, it's going to allow us to get our patients better more quickly, get our patients better with a perceived level of care or perceived experience better. If I don't have the data to back that up, then what's the point of spending all the money on the front end? So we have gone to using a Net Promoter Score to do this. Is anybody here familiar with Net Promoter Score in general? Or Strive Hub, we'll talk about in a second, is who we use to do it. I'll give them a free plug. So the Net Promoter Score is literally the only question. There's a book called The Only Question That Matters in Business, and it's where the Net Promoter Score came from. Satmetrics is the company that has all the rights reserved for everything related to it. On a scale of 1 to 10, how likely are you to refer a friend or a family member to Prox Physical Therapy? That's it. That's the only question we care about. They've done a lot of the data analysis for you to try to figure out what are the percentage of your detractors. That's anyone from 1 to 6 is considered a detractor. 7 and 8 are your passives, those just kind of middling people. 9 to 10, those are your evangelists. Those are people that love you. So Prox Physical Therapy is at an 88, which is, I'm going to brag for a second, we're the highest in the country that Strive Hub works with today. And we've been able to do that even as we've grown 40% every single year. So from where I stand, I have to make sure for all of my partners that, yeah, we're going to continue to grow, but it's not going to dilute the product. We're going to continue to provide the same level of care and the same experience for our patients when we do 15,000 evaluations a year than when we did 300. And this is one of the tools that we do that. What I put up here, though, which is interesting, what this allows us to do is that Satmetrics is doing that promoter score across every industry. And these are the leaders in all these industries. USAA is always the leader in the insurance world. They have an 80% Net Promoter Score, which is unheard of. But these are the other people that we can stack ourselves up against. In therapy, our patients really like us. We tend to be, not me as in Prox, but us as a profession. We're gregarious people. We're outgoing. It's why these conferences are fun, right? Because everybody's going to have a good time, and they're people that we all want to be spending time with. So therapist scores tend to be higher than this. But what we've started to do is take a look at, wow, that didn't come out very well, sorry. So on the bottom left there is an NPS by provider, right? So what I can do here, is this going to give me feedback or anything? Is take a look at 8 different therapists inside of one facility and see, is there variability in the experience provided by my 8 different therapists, or is it close? Do I have an outlier or do I not? I can also do it based upon the body part. So I have the ICD-9s plugged in there to fit into different body parts, so I can see my new therapist, is he or she really struggling with back pain, but it's no big deal when he gets to knees, or vice versa. It just allows you to take a look at the data in a different way. And to go back to Jerry's question a little bit about the who do you hire, new people, old people, whatever else. I have two good stories about that. So we have this new therapist, his name's Keith Cooper. As soon as we hired him, he's a new grad, he's just one of those people that you know is going to be, he's going to be able to do anything he wants in this industry. Just a phenomenal clinician, great hire for us. And he took me aside one day, I'm walking through the clinic. The clinic had experienced a surge in volume. We were trying to get them help from a resource standpoint, but we haven't done it yet. So he was really busy, there's no question about it. And he takes me aside, Ben, I'm just out of school. I feel so overwhelmed by this. I know the patient experience is suffering. There's no way they aren't feeling what I'm feeling. I need help. I don't know how to do this. What was really cool about having data and having actionable data is what I could tell him at that moment was, Keith, I appreciate that you're overwhelmed and you're stressed out, and we got to figure out ways to help because we are looking for resources that's going to help, but let's take a look at the rest of your day and figure out what else we can do to make your life easier. But oh, by the way, you have the highest NPS score of any clinician in our entire business. So whatever you're feeling, let's not project it onto your patients because they're not feeling it. So let's fix the problem, which is he had some workflow issues and efficiency of how he was using the documentation system wasn't great. And we had to help him with that. But we didn't need to say, the sky is falling, my patients hate me, no one's ever going to come back because I'm too busy. And so it just allowed us really to dial down to the actual problem. And the only way we were able to do that is from data. Because if we didn't have this data, we would have just taken Keith's comments at face value, right? And we would have probably thrown another body at it and make sure that, oh, they're treating too many patients. We got to get more resources in here super fast. The patients are all going to be upset. But it just wasn't the case. Then there's the flip side of managing a clinic culture that's focused on the patient experience. We had a therapist who wasn't delivering the care that we expected. He just wasn't living up to what we call the Prox promise. He was an outlier, and you could feel it, and you could see it. We also had data around it. So we had an employee whose performance we could manage based upon data. Your patients are saying X. You need to get it to Y, or we're going to have to have a difficult conversation. And it wasn't about feeling. I mean, from an HR standpoint, it makes life a lot easier, right? Because we're not making any employment decisions based upon, gut feeling or anything like that. No, this is the expectation. Your score needs to be 80 or above, just like all the rest of your peers in the same clinic treating the same patients who are already there. And we're going to help you. We're going to coach you. We're going to do whatever we need. But the standard is not negotiable. It's hard-coded data that we're going to use in order to help you get better. There's not a happy end to that story, but it did allow us to make a decision on personnel with concrete objective information, helping support our clinical philosophy that the patient experience is paramount. And to be able to have data that can drive that variability in care down, so he had that variability not necessarily in the clinical care, but in the customer service experience, it was very powerful. So even though I grew up in Mississippi, I am a New Englander at this point. I talk way too fast, and we just got through just about everything. So before we go to kind of summary stuff, any questions about outcomes, how we're managing all that sort of stuff? Yes, sir?
If he has performed poorly, so he has to be standard. Is that standard set by the therapist in the clinic, or is that standard set by a nationwide database?
Interesting question. So I know the Strive Hub guys well enough that I can just ask, hey, what's the average score of therapists across the country? And I think theirs is around 72 or 73, if I had to guess. Our standard is 80, because that was the other beauty of this product, right? Is because what I could say to this therapist is, hey, your peers in the same clinic as you, treating the same patient. So it's not a national standard that maybe your patient demographic is a little bit different, or it's like, no, people are already doing it in this facility with your patients. It can be done. It's not an artificial number. It's not one that doesn't apply to us. And so that's how we do it. We just decided, it was 80, frankly. We just decided one day, we said, hey, this is what our score is as a company. This is what we think is acceptable, and off we went.
What's the minimum amount of clinicians you should have to establish a standard for your clinic?
I mean, I think one. I mean, for lack of a term, because it's not a statistic. I'm not doing this from a statistical research standpoint that I have to have, the things we were just talking about between the MDC and MCID and all that stuff. I have to decide as a business owner what's important to my business. How do I benchmark it? In the same way that you decide what's an appropriate productivity level, in the same way you decide what an appropriate cancellation percentage is, we can all differ about that. What I'm just suggesting is you need to have one, and you need to decide what it is, and you need to help provide feedback to people, positive or negative, in order to help them get to that level that you need them to be at and stay at. Does that make sense? Yeah. Yes, ma'am.
Yeah, I was wondering if you could speak to what you consider an acceptable capture rate when you're getting this data from your patients, and how you promote getting a high rate.
That's a great question. So this is an electronic tool, right? So we're doing it via email. We have once again, we have a lot of, we just have expectations that are very concrete. We expect our front desk to collect 80% of our patients' email addresses. And that's just written in stone. So 80% of these go out. So 80% of our evals we're getting data to, and we're getting 50% back. So that's what ours has been. We look for ways to drive it up. But if you start looking at, I'm sure all the marketing people in here can tell you that if you're looking at open rates and click-through rates in the 50% and above range, like that's untouchable. Anyone in the world of marketing would pay really good money to get that. And it's because you already have those people engaged and in your system. We also use the system to send out content to keep people engaged in their in their care. So we're using it for a couple of different ways, but that's why, to go back to whoever's question it was about managing that performance of that clinician who wasn't up to the standard, that's why we needed to have a sample in his clinic, because different of our clinic, we have some clinics in very urban, high Medicaid population environments, and we have other very suburban. We're in the financial district of downtown Boston, where there's not a Medicare or Medicaid patient to be found. So we needed to have data to be able to compare and benchmark so that we knew that the expectation was even possible. Jerry.
Do you have a library of evidence-based clinical guidelines that you utilize in the clinic?
You just set me up right now.
Oh, cool.
So we do. We have a starting point. What I would tell you the problem with evidence-based practice is that it gives us an idea of what is best in that moment in time, but there's no evidence-based practice that says over the course of 10 visits for this patient, you need to do this on visit 1, this on visit 2, this on visit 3, right? It just doesn't exist. So I don't have anything that backs that up, and that's where you have to come up with that clinical philosophy. You, as the leaders of your organization, have to decide what's important to you. Hopefully it's guided by your knowledge as a therapist and your reading of the literature. But then you're going to have to fill in the gaps. You're going to have to make some estimations on what you think are the things that it's going to take to get someone better. And then you just need to build your pool of data. And to steal from clinician at their expression, you need to fail fast. That if you realize that you're not where the national standard is, or it's taking you longer or costing you more to deliver the same outcome, you need to be humble enough to be able to take a step back and say, hey, this isn't working. For us, we have a large enough data pool that I can tell you for certain our most trained therapists get patients better in fewer visits, they have a better customer service experience, and they have better clinical outcomes. So that's the data that we're able to pull from it. Does that mean that we're doing it the best way and that we can't learn from anybody else? Absolutely not. But that's kind of where we're at right now. Yeah, so I think there's one thing that I didn't bring up, which is an excellent one. If you do have that special therapist that's just doing women's health or just doing, kind of vestibular stuff, I would almost, Nancy, close your ears, I would almost treat that as a separate practice in some ways with its own, not NPI number, not tax ID, but its own set of expectations. Because I don't know that you can pull and compare those two things and get anything that's good and actionable out of it. But at the same time, you still need to have some benchmarks and expectations of that person. They just might be different than the rest of everybody else. To your question about all of these people and pooling the data, you can do whatever you want with the data because it's all there to be had. What I'm saying is it's very risky to make conclusions around data coming from a heterogeneous mix of therapists that are all doing different things. The more we're able to minimize that variability in care, the more powerful your data is going to be, so that then maybe I can give it to Jerry and he can go publish a paper about what to do over the course of 10 visits. Does that answer your question? Yeah, maybe, probably not. All right, anything else? So, is anybody here familiar with Atul Gawande? So Atul Gawande is, he writes for the New Yorker. He's a Harvard-educated doctor, and he's written the Checklist Manifesto, some phenomenal stuff. I would absolutely check him out. One of the true, overused term, thought leaders in medicine right now, thinking about things in a totally different way. He talks about high reliability industries. The airline business is the easiest one for me just to think about. Think about all of our patients and how much better we get them and how often we don't, so that failure to succeed with therapist rate. Imagine if you had that same amount of failure with the pilot getting you from point A to point B. You can't have it, right? Because no one would ever fly again. So he talks about what are the things that create a high reliability industry, and checklist is a tremendous part of it. So every time I go in and I do a surgery, if I'm really good, I should be counting my instruments in and I should be counting my instruments out. I should be giving prophylactic antibiotics. All those other, I should be writing, is it the right or a left, and everybody has to initial. All those things that surgery has started to do it, but the reason they've started to do it is because they were failing. And they were having higher than acceptable infection rates and recidivism rates and all those things. So this article was published in the New Yorker, but it was actually just a reprint of his commencement address at Harvard Medical School. And it's called Cowboys and Pit Crews. In medicine, in healthcare in general, we all want to be cowboys. We all like the idea of being innovative and different and cutting edge and doing something that the next guy next door is not doing. And that's how we got to that slide way back that I showed you. That's how we got to the point where we're all doing 30 different things and 30 different practices. The problem with that is, if you actually start looking at just overall data, the less variability there is, the places that work more like a system tend to be cheaper and they tend to get better outcomes. And so we, as an industry, need to push ourselves in that direction and not be so arrogant as to say, hey, I can't have a protocol. I can't have a way of going about doing business. I'm a therapist. I know what I'm doing. Well, yeah, you might, but 30 of you are doing 30 different things. So we need to come up with some sort of consensus about what it is that we think is important and do it every single time. And when you do that, that's when you start to get that powerful data that you can actually analyze and get good, meaningful information from. And frankly, if it starts from the care that you're providing your patients and delivering a phenomenal outcome from a clinical perspective as well as a service perspective, then that's when we all win. And that's when all of a sudden we're really able to push things forward, become that primary care provider in the world of orthopedics, but without losing who we are as clinicians. And I believe that's it. That's a terrible headshot. Let's get right off that. All right. I got 5 minutes. Jim tells me I have 5 minutes if there are more questions, but hopefully we got through a lot of them. Yes, sir.
Jim, what's the mix? What's your patient mix, orthopedic versus family practice, as far as your referral sources?
So we have 15 clinics in 15 very different areas, so it's very clinic specific. So one of my personal missions for the organization when I took on this role was every single year, I wanted us to rely upon physician referrals less and less and less. And so last year was the first year that we ask every single patient that gets referred to us, how did you hear about us? And last year was the first year that number was under 50%, had anything to do with physicians. So that's the number we're trying to drive. But if I had to guess, coming from orthopedics versus primary care, I'd say 15 to 20 from ortho, and all the rest is coming from primary care docs. But that also includes all the people that just call their primary care doc and say, hey, I need a script. So I don't know if that's even helpful. But that's, one of our missions really is we want to be less and less dependent. From a business standpoint, it's just risky, right? If you're dependent upon one or two guys to fill your doors or to fill your seats. So that's what we've been working on.
How much are you referring back the other way?
I don't know is the short answer. I'm not right now tracking how many referrals we're sending back out to anyone else. I would absolutely be making that up. Not very many would be my guess, but I don't have any data around that. I probably should. Yes. She asked if I had any advice on recruiting therapists from the fellowship program. I think it's if you find that you have a a pipeline of therapists out there, maybe even that aren't devoted to you yet, I think the first thing is for you to find that organization that's producing them and align yourselves with them somehow. So take more of the students from the university that produces really great PTs, Boston University. Or take, if there's a fellowship program that's really churning out some really talented people, find out how can I be a mentor on staff or faculty there so that you have an in with them. But I also think that people that are going through fellowship programs that are truly lifelong learners that want to push the profession forward are looking for like-minded people with whom to practice. So the number one thing I would say is create a clinical environment where that person wants to work. Create a place where learning is important, it's valued, it's invested in. And that, I think, would be a start. All right, thanks, guys.